Stroke distance, also known as the velocity time integral, VTI, is the area within the waveform and is the basic measured parameter upon which calculations of stroke volume, SV, all other cardiac output, CO, and indexed measurements are made. SV is the parameter of choice for fluid management protocols. However, changes in SD or SVI can also be utilized. Flow time is measured from the base of the waveform and depends on heart rate, left ventricular filling and afterload. Flow time is corrected to a heart rate of 60 beats per minute and is inversely correlated to afterload and can be used instead of systemic vascular resistance. Normal range 330 to 360 milliseconds, representing 1/3 of the cardiac cycle. A short FTC of less than 330 milliseconds often points to an increasing afterload. The most common cause of this is hypovolemia, a condition where there's an abnormally low volume of blood circulating in the body. Hypovolemia causes the body to compensate by constricting blood vessels, which in turn increases the afterload. If the FTC doesn't increase after a fluid challenge, you should consider other causes of vasoconstriction, such as excess vasopressors or hypothermia. A long FTC, i.e., greater than 360 milliseconds, is seen in conditions associated with a low afterload, e.g. sepsis or anesthetic drugs. Peak velocity, PV. The fastest velocity measured at each ejection, seen at the top of the waveform. Normal ranges are shown in the table. Note, any normal values are for a healthy resting individual. It may be more appropriate to aim for optimal values, not low, in clinical situations. Mean acceleration, MA. The average acceleration during ejection, measured on the upstroke of the waveform. Normal values are not available, but trends can be used. Both PV and MA are markers of contractility, but will also be affected by changes in preload and afterload.
The descending aortic signal is the tallest, brightest waveform above the line, with loudest, sharpest whip crack sound, incisors near to markers 1 or 2, or nostrils near to markers 2 or 3. Note this position to find the signal easily again. Recheck at different depths to ensure the optimal signal has not been missed. The venous return signal shown here has a slower whooshing sound and appears below the baseline. This suggests the probe is positioned too low within the patient. Rotate the probe slightly and withdraw if necessary. No results are displayed on the screen. Notice the intracardiac signal. Flow appears above and below the baseline, sounding fast, like a galloping horse. If this occurs, refocus and adjust the probe depth. The pulmonary vein signal appears below the baseline and may sound similar to the descending aorta. If you're hearing this signal, it indicates the probe isn't inserted far enough. Please advance the probe to the correct depth marker and gently rotate to locate the appropriate signal. Celiac axis signal indicates the probe is too low, the waveform is wide and diastolic flow tapers down to baseline. This signal will give improbable results.